El profesor Bader estudió física en la Universidad de Liverpool, seguido de una maestría en física médica y un doctorado en la Universidad de Southampton. A lo largo de estos años ha trabajado como investigador y docente en distintos centros y universidades, siempre relacionado con los aspectos de ingeniería médica, materiales biomédicos y bioingeniería. Fue precisamente en el Centro de Ingeniería Ortopédica de Oxford donde su investigación se centró en los aspectos de ingeniería en la prevención de las úlceras por presión. Entre sus intereses de investigación pues incluye la aplicación de soluciones de la bioingeniería a aspectos concretos de la prevención de las úlceras por presión, las pruebas de imagen aplicadas a los tejidos blandos, el acondicionamiento biomecánico a nivel celular para ingeniería de tejidos y biomecánicas celulares y tisulares aplicadas a la salud y a la enfermedad. Fruto de estas distintas líneas de investigación, pues son sus más de 160 artículos científicos publicados, así como la edición de 3 libros, uno de los cuales me gustaría destacar que es el publicado en el año 2005, dedicado a la investigación en úlceras por presión, perspectivas actuales y futuras. Desde el año 2000 ha sido profesor a tiempo parcial en remodelación de tejidos blandos del Departamento de Ingeniería Biomédica de la Universidad Tecnológica de Eindhoven, en Holanda, y más recientemente profesor visitante en el Departamento de Cirugía Ortopédica en la Universidad de Malaya, en Malasia. Asimismo, ha formado parte de la directiva de distintas asociaciones y entidades científicas. Entre las más cercanas a nosotros estaría la GNEAUPP, de la cual pues, fue elegido miembro del Consejo en el año 2010. Es editor también de la prestigiosa Journal of Tissue Viability y ha obtenido importantes premios y galardones a lo largo de su trayectoria profesional. Dicho esto, prepárense para conocer de primera mano los últimos avances en cuanto a la causalidad y etiología de las úlceras por presión, el uso de biomarcadores en la prevención de estas lesiones, así como el rendimiento de las superficies de apoyo desde la perspectiva de la bioingeniería. Con ustedes, el profesor Dan Bader.
Buenos días. I would like to thank the organising committee for inviting me to this fantastic venue and this fantastic meeting. And it's always nice to get out of London in November, where it's always grey and murky, so it's very nice to see blue skies in November. What I'd like to talk to you about in the next 45 minutes is the role of bioengineering in pressure ulcer prevention. As you can see, I'm now associated with the University of Southampton, but I also have had a long-standing association with the University of London, Queen Mary University of London, and in the last 10 years I've also had a part-time position in Eindhoven University, and much of what I'm going to describe today is based on what was achieved in both London and Eindhoven, and more recently in Southampton. This slide shouldn't need to be given, but I'm just putting in a definition of pressure ulcers. If you go back in history, they used to be known as bed sores, or more recently pressure ulcers or decubitus, and the definition according to the European Pressure Ulcer Advisory Panel and the National Pressure Ulcer Advisory Panel is a pressure ulcer is a localized injury to the skin and or the underlying tissue, usually over a bony prominence as a result of either pressure or pressure in combination with shear and or friction. The first recorded pressure ulcers were way back, and there's a very interesting analysis of some of the Egyptian mummies in the British Museum, and it's suggesting that that was the first signs of pressure ulcer over the greater trochanter of an Egyptian mummy, the priestess of Amen, and it was at the time treated with gazelle skin. So in other words, that may well have been the first ever tissue-engineered graft over a pressure ulcer. More recently, bringing it right up to date, it's become a very international hot topic. And one of the reasons for this is because it's been implicated as a quality of care index and a quality of safety index. We know it's a burden to both individuals, to the carers of the individuals, and of the institutions, the health services, the elderly homes, the care homes, and the community. And we also know that there are a number of degrees of damage which are classified as stages or grades 1 to 4, as well as the more recent damage mechanism, which actually is called deep tissue injury, where it starts in the deep tissue and then works its way up to the skin surface. We also know that many of our population can be involved. So from neonates in incubators, where they are supported and they get quite often pressure ulcers at the back of the head, or ulcers associated with medical devices that are impinging on their soft tissue, through to spinal cord individuals who may have their injury, say, late teens, and they are at risk of developing pressure ulcers for the rest of their lives. We also know that the elderly who are bed-bound or chair-bound are also very highly at risk, particularly if they have a number of intrinsic factors. We also know that pressure ulcers can be fatal. And the best example of this is Superman, or the actor Christopher Reeve, who got a deep tissue injury which became septic, and he died of that pressure ulcer. So we must be aware that pressure ulcers sometimes may be mild occurrences that can be treated easily, whereas in other cases their prognosis is variable. So the group and the type of risk factors involved are quite clear now in the literature. So subjects that have limited mobility, those who are chair-bound, sedated, anaesthetised, in acute care or intensive care units, all of them are potentially at risk. Secondly, subjects who have an impaired sensitivity. When we think about the patients that have paralysis or neuropathy, particularly diabetic foot patients, they are likely to be at risk of developing soft tissue damage in the form of pressure ulcers. Thirdly, and from an engineering point of view, this is one that is very interesting to me, is that some soft tissues are more vulnerable to pressure-induced damage than normal. And the example I've given here, or the examples, are those that have tissue breakdown or tissue atrophy, for example, following spinal cord injury. Those people that have loss of muscle tone, so they have what is called flaccid paralysis, again, they are at risk. And also patients who are dehydrated and malnourished and their tissues are not as healthy as normal. Even normal pressures can produce soft tissue damage. And a number of years ago, we also identified that patients during surgery, this is a patient who is having a management of their fracture of neck and femur, that patient, they are anaesthetised, they are on a support surface which only part of their body is supporting their whole body weight, and they are at risk. And sometimes when they go aftercare after their surgery, then there are signs of tissue damage, and we believe they may well have occurred during those surgical procedures. So the approach that we have taken, and I say we, it's a collective we of a large number of colleagues who've worked with me over the years, is what I call a hierarchical approach. So clearly the people we are most interested in are the patients themselves. And this is a patient who was photographed in an elderly unit in a poor area of the East End of London. And this patient would sit in this sort of position on her chair with all her bags and her belongings around her for 8 to 10 hours a day. And she was also sedated under some drugs and therefore was clearly at risk of developing an ulcer. So we're interested in the patient. We're also interested in imaging the patient. So this is a MRI image of somebody sitting down looking at the deformation of the soft tissues using this imaging technology. Although I'm not going to talk too much about that, we can convert this image into an engineering analysis where we try to estimate what the internal stresses and strains are, the mechanical state of the soft tissues, using a technique which is called finite element analysis. We've also looked at animal experiments to try to understand more about the progress of damage as a result of mechanical loading. And I'll briefly mention some of the results of that at the end. And then we can also look at the pressure-induced damage at a cellular level. Remember, pressure ulcers start at cellular level. Cell death occurs, and that leads to an accumulation of tissue damage and then a manifestation of pressure ulcers. So this is the approach we've taken, looking at the human, looking at animal models, and looking at cell models as well, using techniques which are largely engineering or bioengineering in origin. So what causes a pressure ulcer? Well, the most traditional explanation is that there is localized ischemia. So by squashing the soft tissues, you squash the blood vessels, and that stops or prevents the delivery of the vital nutrients, namely oxygen. That's the traditional mechanism, this ischemic mechanism. This occurs, but we also believe that there are other mechanisms that are at play as well in the causation of pressure ulcers. Secondly, when you squash the tissue, you're also going to affect the lymphatic flow and the lymphatic drainage. So what the cells produce, the so-called toxic products, will not be released or removed away from that localized area, so that can lead to cell death as well. Thirdly, and quite controversially, we believe that even during the reperfusion phase, where load is removed and blood goes back into the localized tissue, that blood is delivering oxygen, and that might lead to a build-up of toxic levels of reactive oxygen species. And we know those molecules are potentially damaging to the viability, the health of the cells. So we know that that can be a problem as well, even during the relief mechanism of following sustained loading. And as I mentioned in the last slide, we can also show that if you squash the tissue, you get direct cell damage as well. So by compressing a cell, you can damage the mechanism of the cell as a result just of direct squashing the tissue or loading the tissue. So we now believe these four mechanisms occur. They occur at different times, at different stages of pressure ulcer development, as I'll mention later on. So what can we do as bioengineers? Well, first of all, we can develop measurement systems to monitor patients being supported at the patient support interface. So at the interface we have interface pressures, and shear forces are forces parallel to the skin surface, and we can actually measure those pressures. We can measure the pressures when people are lying down or supported in a chair. But what we need to be able to do is to relate those external forces, this is the skin surface, to the mechanical stresses and strains within the soft tissue, because that's where the damage occurs. And what we'd like to be able to do is to develop objective screening methods which will indicate those patients that are particularly at high risk of developing pressure ulcers. Now, I know there are some nursing scales available to us, the Norton scale, the Braden scale, etc., but they are very subjective and limited in nature. What we would like to do from a bioengineering point of view is to be able to use objective screening methods that detected patients, particularly if there are early signs of damage. And once we've done that, we can identify those patients, and with that, we could use appropriate prevention strategies or intervention strategies. For example, advanced mattresses and seating systems. Now, just briefly, the factors that are important, the so-called extrinsic factors, the factors that the patient is being subjected to. I've said already that pressure is important, but I've put here a deep-sea diver. A deep-sea diver has many problems, but one of them isn't pressure ulcers. And that is because the pressures are the same all the way around the patient, or around the deep-sea diver, should I say. So that's what's known as a hydrostatic pressure. What is important is localized pressure, where you apply localized pressure to one point, and adjacent to that or next to that, the pressures are relatively small. So you have effectively a high pressure gradient. That is what causes the most damage to the soft tissue. We also know shear is important, so we have here somebody in a semi-reclined position, and because there is an angulation of the top half of the patient, then there is a component to the force which is parallel to the skin surface. That's an external shear force. What's also important is temperature, and why temperature is important. If the temperature at the interface between the patient and the support surface increases by 1 degree centigrade, then the metabolic rate, or the demands of the soft tissue, increases by 13%. So the warmer the tissues are, the more metabolic activity needs to occur. And if it's being compressed because of the result of external pressure, that will be compromised. Also associated with temperature is moisture. And we know that wet tissue is more likely to break down than dry tissue, particularly if it's associated with patients who are incontinent. Time is an important factor, and as I'll mention in a few minutes, tissue viability or tissue status is also very critical in determining which patients are at risk and which patients are less at risk. Just to show you that mechanics or engineering can evaluate what is happening simply within the tissue, that if you apply a constant pressure as the result of this weight on a block of tissue, so this is simulating bone, this is the soft tissue, and if you look at a diamond shape in that tissue, when you apply a normal force or a force perpendicular to the skin surface, you see that this diamond shape has been stretched in this direction. So what I'm saying is that even normal pressures cause shear stresses in this direction within the tissue. So we have both external shear, where you slide this across the skin surface, but you also have internal shear, and that's particularly the case between the skin and the fat and the fat and the muscle layers. So they slide as a result of direct pressure. And that was first recognised way back in 1958. So it's well known that shear can occur outside the body as well as inside the body. Now, we developed many years ago, when I was based in Oxford, in a pressure monitoring system. So we developed a system which was called the Oxford Pressure Monitor, and there was a series of cells which you could sit on or lie on, and it would record the pressure map underneath the patient. More recently, there are more advanced systems that have been developed, such as the TET scan system, which gives you fantastic pictures or images of the pressure profile, for example, in a wheelchair. So this is a pressure profile of the high pressures indicated by yellow and red underneath the sitting patient. Now, these systems have some advantages, but they also have some limitations. So one of the advantages are that they provide very good assessment of one support surface compared to another support surface. So, for example, one cushion against another cushion. You can map the pressure distribution and see what provides the most uniform pressure. They are also very useful as a feedback tool for posture. So if somebody is sitting down and lying on, or sitting on one side, you will see a much higher pressure on one side than the other side. And so it gives an indication to both the patient and the carer that their posture needs to be balanced to provide a uniform pressure underneath the patient. However, there are limitations, and the new systems provide large data sets. So you get maybe 1,000 values of pressure underneath somebody sitting down. That is very difficult to analyse. So one of the disadvantages is that that you have to analyse large data sets, and the other very important limitation is that these external interface pressures do not necessarily relate to the pressures within the soft tissues themselves, which is what is causing the damage. So with that in mind, I'm concluding that pressure measurements alone are not sufficient to alert the clinician, the carer, to areas of tissue breakdown. And what we need to be able to do is to analyse the effect of the pressure and time on some measure of tissue viability or status. So for the most part now, I'm going to be talking about measurements of tissue viability or tissue status. Now, there are many techniques that have been proposed to evaluate the effect of pressure and time on tissue viability. And I've listed 5 of those, and I'm going to be talking about 4 of them. So first of all, I'm going to be talking about transcutaneous gas monitoring, where you measure the local levels of oxygen and CO2, carbon dioxide, in soft tissues that are being loaded. And I'll give you some examples of that. The last 3 techniques, sweat biochemistry, early biochemical markers, and measurements within urine and blood, are all means of measuring tissue viability using what are called biomarkers, and I'll be describing different possible mechanisms of biomarkers later on. So what we found when we used transcutaneous oxygen monitoring, that there is no one single interface pressure which is going to ensure the health or the viability of soft tissues in all individuals. That's not really surprising because there is so much variability between one patient and another patient, and even within one patient, one site and another site. And what we showed was that if you apply load and then remove the load, so we're applying a load here, we're removing the load here, we're applying the same load again, and we monitor tissue viability against time. If you measure a large number of subjects, you get 2 distinct responses. A normal response, which is shown by this continuous line, and a dashed response, which we are considering to be an impaired response. Now, the difference are that as you apply a load and remove the load, the impaired response doesn't fully recover back to the normal level. When you apply the load again, it decreases. So what we have in an impaired response is a slow decrease in tissue viability, which is measured by oxygen levels. And what we found was that when we looked at specific patient groups, we found some patients responding in a normal response, which would be the same for ourselves, assuming we are all able-bodied, and comparing that with another group, a subgroup, who were very early study. We then wanted to evaluate it with a group, a selected group of patients who we knew to be at potential risk of developing pressure ulcers. So we went to the UK National Spinal Injury Centre, and we evaluated a whole group of patients prospectively. So over a period of 3 years, we actually monitored 42 spinal cord injured subjects, and we categorised them depending on whether they were high-level lesions or low-level lesions. And we monitored them, we measured their pressures, we measured their tissue viability over a period of 1 year following injury. And we monitored them for at least 2 times, but sometimes up to 6 times. And we didn't influence what they were being given. So the therapists and the nurses prescribed the cushions, and we just evaluated the effects of those cushions on tissue viability. And an example here, this is a low-level lesion who has spastic paralysis. He was sitting on a relatively simple cushion, a standard foam cushion. And you can see these arrows here indicate when he was moving. So he was either moving up and down, lifting himself up, or leaning forward. Or leaning forward. And each time this happened, you could see that the oxygen levels recovered to a relatively high level. And when he leaned forward in his chair, you can see the oxygen again rose very high. So this cushion was sufficient to support this patient over a period of time. However, we found a subgroup of patients within the spinal cord injury group who were particularly at high risk. What's happened? We found that those patients that had flaccid paralysis were at particularly high risk of developing pressure ulcers. So those people that are low-level lesions, so they were below the thoracic level 6, that's where their lesion were, and they had flaccid paralysis, so their muscles were not contracting normally. They were the ones over a period of 12 months where the pressure ulcers were likely to occur. They were a high-risk patient. And this supported an earlier clinical observation in Australia, which showed that these flaccid paralysis patients that were particularly at high risk. By contrast, patients that were low-level lesions but had spastic paralysis, that meant that muscle contractions were normal, were not at high risk. So we identified a subgroup who were particularly at high risk. That was then moved on and was used clinically as a clinical tool to assess patients who came into the National Spinal Injury Centre. And the interesting findings from this study, which was reported in 2003, said that to recover back to normal level of oxygen required, on average, nearly 2 minutes. And if you compare that with a spinal cord person lifting themselves up from the chair, the time in which most spinal cord injured patients could do that was about 30 seconds. So it wasn't long enough for the tissues to recover back to the unloaded levels. So the recommendation from this study by Lorna Rose and Maureen Coggrave was that there needs to be other strategies, such as if the patient had stability, if they could forward lean in the chair or tilt back, because that's a much more effective way of relieving pressure than lifting themselves up out of the chair. Now, the problem with this measurement of transcutaneous oxygen and carbon dioxide, although we use it regularly, it is expensive technique and it can't be used as a screening tool. And that's really what we're looking for, a simple method of screening out a large group of patients. So for that, we started off with saying, well, can we somehow interrogate what is in the soft tissues by collecting a fluid that is on the skin surface? And the one thing that you can measure at the skin surface is sweat, as I am sweating at the moment. What we can do is we can measure the sweat in a loaded tissue and compare what's in the sweat, what are the biochemicals within the sweat during an unloaded phase and a loaded phase and see whether we can measure some sweat biomarkers that are indicative of early tissue damage. So, can we measure specific metabolites that are accumulating in the soft tissue during periods of loading? And so we set up an experiment where we combined transcutaneous oxygen monitoring. So we used an indenter, we loaded the indenter up. This is a colleague of mine lying on the front, and we loaded the sacrum up. We measured the oxygen levels and CO2, and then in this ring here, we used a simple filter paper to collect sweat, and we then analysed what was in the sweat. So we were using two different techniques, transcutaneous oxygen and sweat markers. And what you can see, so we did this experiment in a controlled temperature and humidity because we wanted the normal ambient conditions to be standardised. We measured the oxygen and we measured the sweat levels, and I'm only going to show you in this first slide sweat lactate. Why we measured lactate is because lactic acid suggests that cells are no longer going through aerobic respiration. There's not enough oxygen, so they're going through glycolysis and producing lactic acid. So this slide shows, it's a spotty slide where the red spots indicate the unloaded sacrum. So we have oxygen levels and levels of sweat lactate, and you can see across a group of volunteer subjects the oxygen levels are relatively high and the lactate levels are on average about 40 units. However, in the loaded region, so this is where we measured the sweat when we were loading the tissue, not surprisingly, the oxygen levels, these are the yellow dots, the oxygen levels have been reduced, but also there is a build-up of sweat lactic. So in other words, as the oxygen decreases, the cells are going through glycolysis, producing lactic acid, which is collected in the sweat, which we can measure at the skin surface. So it's a relatively simple technique to look at what is happening within the tissue. So I won't go through that one, and I'm going to have problems getting to the next slide. Oh, sorry. We can also show, using another type of analysis, in this case looking at loading and then subsequent reperfusion, that some of the markers, and this is looking at a different number of markers, these are called purines, which are indicative of tissue damage, that you can see that even in the reperfusion phase, so we're collecting sweat after the loading phase for 30 minutes and then a subsequent 30 minutes, if we look at, this is the ratio value of loaded to unloaded, you can see many of our markers are higher even during the reperfusion phase. So even when we have loaded for a period of time and then removed the load, those potentially toxic biomarkers are still in the tissue. They haven't been removed from the area. So potentially further tissue damage can occur. So this is a good technique, but it is limited in a number of ways. And one of the ways it's limited, as I said in this slide here, is that there are technical difficulties in producing a range of biosensors. this may be in the future something that we can do, develop simple biosensors that can monitor some of these markers, and also some patients have abnormalities in pseudomotor function, which means they don't sweat normally, and an example of this is spinal cord injury. So it can't be a universal tool using sweat alone. So another type of biomarker is a biomarker from the outer layer of the skin, the epidermis. And one of the molecules that is released from the epidermal cells, which are called keratinocytes, are markers called cytokines and chemokines. And these are potentially inflammatory markers that can show some sign of increase during mechanical stimulation. So we wanted to see whether we could collect these cytokines and chemokines over normal tissue and then have a look at whether they were increased over pressure ulcers themselves. So the first study was on normal volunteers. So we used a very simple mechanical loading system. So we had a load frame and we were loading the forearm, and under the load we were collecting the cytokines with a small piece of sticky tape, which is called Cebu tape, which collects what is released from the top surface of the skin. So our first experiment was to see if we loaded the tissue, whether there was an increase in the amount of cytokines released under the loaded tissue, and to see how long that release was maintained. So what we're looking at here, again, is a ratio value. So this is a ratio of the one cytokine, interleukin-1 alpha, over a loaded area compared to an unloaded area. So a value of 1 means there's no increase. And what you can see was that over the loaded area, the amount of increase in interleukin-1 alpha, a cytokine, was 2.5 times that from the unloaded area. So it was very sensitive to loading. And this occurred both initially at 10 minutes and 20 minutes after the loading phase. So the amount of release was maintained 20 minutes after loading had been applied. This was on the forearm. And we've compared it with TS, which is tape stripping, where you get some Scotch tape or elastic tape and you just strip the epidermal, and that releases cytokines. You can see the value of increase is greater when we apply mechanical loading. So we translated that into a clinical setting. So we did the same study using the same methods, but we weren't loading, we were just looking at the release over a grade 1 ulcer. So we were again applying this Cebu tape over a grade 1 ulcer on a very small group of patients in the Netherlands, in Eindhoven. And what you can see is, if you look at the range of values, again, of interleukin-1 alpha, you get a massive upregulation over the ulcer, but 10 centimetres from the ulcer, the release is the same as it is in another area. So the localised release is very distinctive. So again, it might be used as a biomarker for early damage, as is seen in grade 1 ulcer. So we're looking to develop biomarkers And there has been, as you can see, a paper in 1988, that is 30 years ago, where they suggested that biomarkers in fluid may be also indicative of whether tissue damage had started. This work was done on spinal cord injury patients, and we did another study in the last year where we analysed the blood levels of spinal cord injured patients, compared it with able-bodied patients, a very small study involving a small cohort of subjects. So this is the study: 7 able-bodied controls, 7 spinal cord injured patients without a pressure ulcer, and in the pilot study we had 1 with a pressure ulcer. And we were looking at 4 distinct different biomarkers, so MB, CRP, CK and HFAP. And I'm going through this this is a large amount of data. I don't expect you to analyse that, but we did see differences between able-bodied patients or spinal cord subjects that didn't have a pressure ulcer and the one, that did have a pressure ulcer. You can see a number of the markers are severely elevated. This is measuring in the blood. So this study, I'm sorry to have gone through it quickly, it's only just been published in 2012 in JRRD, which said that if you measure biochemicals in the blood, you may be able to indicate whether damage was occurring or whether it was start to occurring. So there is hope that by being able to use biomarkers, we can have a screening tool to indicate early damage. I'm just going to finish up with saying what we're doing now. We've been, as I've moved in the last year and a half, we now have a clinical academic facility in the hospital, in Southampton General Hospital, and we can do studies on patients routinely, and that's why I've moved to Southampton, to translate some of these techniques I've been describing into a clinical setting. So what we can do is we can look at alternating pressure systems, we can look at patients in surgery, and we can look at spine boards. And I'm just briefly going to say what we've been doing in the last year in Southampton, and I've switched that off again. This is an alternating pressure mattress, and this is a prototype device, and the beauty of this device is that the actual alternating pressure area, the pressures depend, the air pressures within the mattress vary depending on the weight and the shape of the patient. So you can adjust the alternating pressures depending on whether you have a light patient or a heavy patient. So looking at that, we have somebody lying down on the patient, we're monitoring their pressures, we're monitoring the tissue viability, the oxygen levels, and what we can do, first of all, to show that as the body mass index increases, as we go from light patients to heavy patients, the air pressure increases as well. So in other words, the mattress is adjusting to the weight and the shape of the patient. We've started evaluating that both on volunteers, and we've just started looking at it with patients in the hospital. And again, we're monitoring the oxygen levels and the pressure levels, etc. And what we found was that in most cases, the air pressure can adjust to the patient such that the patient's tissue viability is maintained during a period of alternating pressure. There are 1 or 2 cases where this doesn't occur, particularly when you lift up the head of bed. So if you tilt the patient, sometimes the air pressure cannot accommodate the weight of the patient. And that is something, again, which we need to look into. And the company we're working in is now looking at the effect of tilting the mattress as well as alternating the mattress to see whether pressure relief can be accommodated. We're also looking, as I said, at spine boards. Patients who are supported on spine boards, quite often are supported once they've had their accident for 2 or 3 hours before they get into the hospital, and they are left on the spine board for x-rays, etc., for another 2 hours. And we believe that these hard spine boards themselves may be causing problems. So we're working with a group in Maastricht and Eindhoven to see whether if you introduce a soft cover inlay within the hard shell, so it's the same shell but in the inside we have a soft inlay, whether you can reduce the effect of damage to the tissue over a period of time which may be up to 4 to 6 hours. So this is an area we're interested in. Now finally, I just want to talk about etiology. We have lots of techniques now available to us. Why aren't we applying those into related to pressure ulcers? So we have a range of techniques from biosensors, which I've talked about, computational modelling, live cell imaging, MRI, magnetic resonance imaging, ultrasound and functional electrical stimulation. Some of the people in the research arena are now beginning to look at these, and what we believe is happening, and I've gone through this slide before, but I'm going to go through it again. We believe that ischemia is important, lymphatics is important, ischemia reperfusion is important, and tissue damage, tissue deformation is important. So we believe all those 4 mechanisms are occurring. And we've done a lot of work in Eindhoven in the Netherlands looking at damage in an animal model, and I'm not going to describe this technique. This is a long technique where we use MRI, magnetic resonance imaging, and then from the images we then analyse what the internal engineering stresses and strains are. And I want to finish up by this mechanism that we think now is occurring. So we've got our tissue with our vessels in it. We apply a small strain or deformation, and the tissue is deforming, but it's below that red line. We believe that strain level within the tissue is quite critical. If we go above that red line, we think we're now starting to cause damage. So we think there is occlusion of blood vessels, which is changing the metabolism within the tissue, which is building up waste products which can't be removed because the lymphatics is occurring. There will be a change in the local pH in the tissue, and that will lead to cell death. If we increase it even further, so we go to a second level of strain, we believe we get direct deformation damage of the cells. So by squashing it or deforming it by a large amount, the cells themselves will be damaged, the membrane that surrounds the cells will break down, there will be a potential disruption of cytoskeleton, and that will lead to cell death. So we believe 2 mechanisms that can occur. This is based on the animal work we've done, depending on the level of strain or the amount of pressure that's causing the strain is occurring. So we now believe that even at low levels of time, so this is at small time periods, if you exceed a threshold limit, you will get damage. If that time is prolonged, so a patient is lying for long periods of time, then the damage level is necessary, or the deformation level, the safe level, is necessarily going to be decreased. We can now use MRI, we can use this technique, finite element, but there's also a group both in Australia, and we are starting to do it in Southampton, to see whether we can see those changes in the soft tissues using ultrasound, which is a much more user-friendly technique than MRI. So that's the approach we're taking. And finally, what are we doing in the hospital in Southampton? Well, we are very concerned about sitting acquired pressure ulcers. The practice in Southampton and in many hospitals is that every 2 hours a patient is in bed, they are turned, which is great. However, once the clinician, the nurse, the doctor thinks the patient is getting better, they are then sat out in a chair and left alone for 8 and 10 hours. So we believe sitting acquired pressure ulcers is a very big, both in the hospital and in the community. So we're putting a lot of effort in that. We're also interested in neonate units and paediatric intensive care units. So we've started to evaluate whether pressure ulcers occurs through pressure alone or through the medical devices. So we've got some strengths and weaknesses in bioengineering, but I haven't time to talk about those. I just want to finish up by saying this work wasn't possible without a lot of support from a lot of people in the UK, the Netherlands, Israel and Australia. Thank you for your attention.
Bueno, pues sintiéndolo mucho, debido al tiempo, no va a ser posible establecer un turno de preguntas.